Good morning, everyone. My name is Dr. Nath, and I'm the section chief of the Stem Cell Transplant and Acute Leukemia Program at the Banner MD Anderson Cancer Center in Phoenix, Arizona. Today, I'll be discussing about how in the Sierra trial, Iomab-B conditioning reduces the toxicity that is associated with stem cell transplant. To begin off, I will talk about what this Sierra trial is and who are the patients that it targets. As we know, acute myelogenous leukemia is the disease of the elderly patients. The median age of this patients with acute myelogenous leukemia is 68 years. If you are older, these patients very frequently do not tolerate chemotherapy well to put them into induction. And a lot of these patients are not considered candidates for allogeneic stem cell transplant because of the toxicity associated with the procedure. The Sierra trial, or study of Iomab-B in the elderly relapsed refractory patients, is a study of patients over the age of 55. It's a randomized study where the patients are randomized 1-to-1, either to a stem cell transplant using Iomab-B or a conventional care, which will be selected by the individual investigator, which they would have done if they did not have access to the trial. If they get randomized to the Iomab arm, they will undergo a stem cell transplant from an available fully matched donor, and the primary endpoint is the duration of remission for 6 months. In case they get randomized to the conventional arm, they'll get the standard of care chemotherapy. If they get into remission, they'll get transplant as a standard of care or conventional chemotherapy. If they do not go into a remission, they can be crossed over to the Iomab-B arm. So the planned accrual for the study is 150 patients, and we have completed 75% of the enrollment over 113 patients. The data was looked by the Data Safety Monitoring Board, and they have asked the study to continue. In the current TCT meeting, there were 2 abstracts. One abstract looked at the engraftment, which was presented by my colleague, and the other abstract, which I presented, looked at the toxicity to the GI tract with the Iomab-B arm. What this study hypothesized was that with Iomab-B, because we are giving targeted radiation, there will be less radiation to the GI tract, and as a consequence, less toxicity, which will result in less mucositis and consequently, less neutropenic fever and sepsis. When we looked at the data, we were able to show that even though the numbers were small, there was a reduced incidence of sepsis in the Iomab-B arm as compared to the patients that were randomized to the standard of care arm, even though they subsequently may have crossed over to the Iomab-B arm. The incidence of febrile neutropenia and mucositis was low and was clearly acceptable. This is because, in contrast to getting a full radiation dose in the conventional transplants, we are only able to give a small amount of radiation dose to the critical organs, including GI tract, and the total radiation dose to the non-hematopoietic organs in this study was about 4 gray.